Kia ora tātou. Welcome. This is Pauline Proud from Mobile Health, and it's my pleasure today to introduce to you our presenter. This is Ruth Barratt. Ruth's topic today is providing healthcare safely in the community. And you will have noticed, because it was planned a few weeks ago, that this was done in anticipation of working with level 2, but of course we're at level 1 already. Ruth is the Independent Infection Control and Quality Assurance Advisor and Nurse Consultant for IPC Biopreparedness at Westmead Hospital in Sydney, and she has over 22 years of experience. Ruth's current role is the development and implementation of IPC protocols and procedures for the management of a patient with high consequence infectious disease within the New South Wales state biocontainment facilities. And Ruth is joining us today from Sydney. Welcome, Ruth.
Thanks, Pauline. It's nice to be here again. I did a presentation a few weeks ago during COVID, and this is just like a follow-up one. So as Pauline said, originally my remit was during level 2, going into level 2, but things have moved so quickly for New Zealand, which is fantastic, that you're now just about into level 1. However, I would say most of my presentation will still be suitable and applicable for any sort of pandemic situation, and so I'm just going to share my screen now so that you can I can start my presentation. So I wanted to focus on the community, so I'm not going to talk about any hospital infection prevention control for COVID-19. I'm really just going to focus on the community and a couple of aspects on the community. And at the end, I have got a number of slides to do with the skin problems that staff are now, healthcare workers are experiencing in using personal protective equipment. So that is applicable to all healthcare settings. But the first 2/3 of my presentation today is about infection prevention control issues to do with community care. Oh, sorry, so when we talk about community healthcare, there's a whole list here of things that I have put together that constitute community healthcare in the community. And I am sure there are some of you who have dialed in today or zoomed in, maybe are in another area of healthcare in the community that I actually haven't thought of. But as we know, there are many, many more types of healthcare provided in the community than in a hospital setting. And each one of it brings its own, maybe unique infection prevention control challenges. And today I'm just going to focus on 2 areas. I'm going to focus on going into someone's house to deliver healthcare, the infection prevention control around that during a pandemic or outbreak situation. And another one is talk a little bit about outbreaks in aged residential care and some of the sort of take-home messages and learning tips from that. So I'm just going to underline that with the principles of COVID infection in community. As I said, providing care in a person's home, managing an outbreak in aged residential care. And that's really, that section is not about all the infection control guidelines for that, but it's just pulling out a few of the key messages and some of the tips from outbreaks that have happened. And then I'm going to finish off with a shorter section on the hazards and with the use of PPE and the injuries that staff are getting and how we might prevent that. And as everybody likes pussycats, I thought I would include a little picture of a pussycat there. So I just want to show you this to start off with. This is a really neat little, I'm going to click onto it in a minute, but it basically compares the deaths due to COVID compared to all the other reasons for global deaths, so deaths throughout the world, from the 1st of March up until the 23rd of May. Now, when I click onto it, it's going to start running. I'm just going to stop it a minute. And what I want you to see is right down at the bottom, you can see there's COVID and you've got malaria, because malaria is a huge killer. And this timeline is going to go from the 1st of January up till the 23rd of May. And what I want you to look out for is this COVID deaths, to see how quickly from the beginning of March it starts overtaking. And the reason I've put this in is just a reminder for us just how devastating this outbreak, this global pandemic has been. And you know, while New Zealand have got away lightly, and Australia, where I am, have got away lightly, and some other countries, at a global level, it is massive. So if you watch that now, you'll see COVID has got 1 death, and you'll see the bar quickly move up. It's a brown bar, and it starts to move up now. So we're into February. There's a number of deaths. It's flicking up. Just point it out here. And eventually it will overtake, but it is such a rapid increase in global deaths compared to the other reasons for death. So we're now into the end of March and into the beginning of April, and it's just racing ahead. And eventually overtakes malaria at the end of April. So that and this is already 6 weeks out of date by the time it finishes. Okay, so I just want to show you that to re-emphasize just how serious this disease is. So if we move on to the presentation now in general, when we're looking at what we do in the community to protect ourselves against transmission or cases of COVID-19, these are the core underlying principles of public health and infection prevention control in New Zealand. So these do not apply to Brazil at the moment. They probably do apply to Australia and some other countries, and they're not yet applying to places like the UK. So you've got to remember when you're thinking about what is the risk of me acquiring COVID in the community or one of my patients acquiring community. These are the principles. So our community transmission is absolutely low, if not zero. I mean, Jacinda Ardern has stated that we have, you know, got rid of COVID in New Zealand, but even if there is some cases out there, the transmission within the community is incredibly low. And that is because our public health surveillance is so robust. We've got excellent public health services. We're doing a lot of testing, and every time there is any suspicion of a case, there is a huge amount of contact tracing. And that is a huge part of keeping our community transmission low. So most of the cases of recent have been return travellers. And in Australia, nearly all our more recent cases in the last week or two have been anybody that's come back who's already in quarantine. So keeping those 14-day quarantine is probably a good idea for now. We do know, despite certain literature, that transmission is still primarily from symptomatic persons. So when you're looking at a risk assessment, we want to be checking for symptoms. We know that there is asymptomatic carriage, but we don't know how much there is. There was a report out a few days ago, and there is so much more to learn about our asymptomatic carriage. We know that there have been studies have found asymptomatic carriage, but we don't know how many. We also don't know how much these people are spreading disease. We do know that they can spread disease within a household scenario or a closed environment where you're living with somebody. But are they responsible for outbreaks, and how much are they really spreading outside of their own household? So it is probably still agreed among experts that transmission is primarily from persons who are symptomatic. So that means we have to revisit the standard precautions. Now, standard precautions, many people did not understand what standard precautions really mean or meant up until this COVID outbreak. And that's what we have to really focus and push now going forward. Think about why you might wear a gown, why you might wear a surgical mask. If someone has got any symptoms of respiratory disease, think about how you can apply your standard precautions. There will still be exceptions going forward into level 1, that you may need to consider that risk assessment. So your very vulnerable persons, or those people who might still be returning, who might be a contact still, or have been identified through public health. And I know that many of my colleagues within the acute healthcare sector or the private hospital sector are still going to apply some risk stratification questions. They're still for, I don't know how long, but at the moment going into level 1, in the hospital settings, they've still got some concern that there may be some people out there and they're going to ask some questions. Overall, don't forget, if you're a healthcare worker, you need to stay home if you're unwell. And there's also, that's for everyone. There's still the physical distancing is important if we can, although not so much now going into level 1. But just push those basic hygiene measures, including frequent hand hygiene. And of course, we're now going into winter. We will get other respiratory viruses. So it's about your respiratory hygiene, your cough and sneeze etiquette. Cannot emphasize how much we need to promote and push those things. So these were the guidelines that the Ministry of Health put out for when you were in level 2. Now, while I appreciate you're now going into level 1, I was asked to do this presentation, you know, not that long ago. And so some of the stuff I'm going to talk about now, although it's aimed at level 2, bear in mind that we may flip back to level 2, you know, as good as New Zealand is at the moment, we don't know that there may not be a cluster. So you may have a situation at a local level whereby there's been a little cluster of cases and you may be wanting to put some precautions that you would have used at level 2 back into place. So I am going to go through some of these anyway, because the basic principles are there and they're always useful to have in the back of your mind if you had a little problem at a local level or nationally, there was some resurgence and a second wave. So the 2 Ministry of Guidelines from Community were these, and they're on their website. And this was around PPE for community care in places of residence and for people going into clients' homes. Now they do overlap, they're not totally separate, and one was on the 14th of May and one was on the 15th of May, and it was a little confusing to me as to why they had these 2 separate documents. However, they are both, none of them say anything against the other, and they're both useful documents. So what PPE should you be considering? Well, certainly at level 2, you're back to your standard precautions. There is business as usual now, but at level 2, you are still having to do that risk assessment. And I will go over the risk assessment because this is about PPE going into people's homes and what sort of things should you consider if you're going to do a home visit for whatever type of healthcare that you deliver. So the key risk assessment questions that you may know off by heart, but I'll just reaffirm them because I think these still apply now in terms of standard precautions anyway. So has your client got new or worsening respiratory symptoms? And remember that with COVID, that not everyone had a fever. And also remember that the very elderly will not always have respiratory symptoms to be unwell with a respiratory infection. So if you're going to visit someone, I still think it's worthwhile you asking them. And, you know, for level 2, that you would be asking the patient to wear a surgical mask. Now in level 1, if you were going there, it would probably be you would be wearing the mask and they probably wouldn't need to be wearing the mask. But that is up to you and what you're going to do. Certainly you would have to arrange at that time to get their test done for COVID-19, which means that if you have to do something while you're waiting to see if they're positive or not, you'd be wearing a surgical mask. And also you would wear a mask and any other PPE if you had to provide direct care while you were waiting the test result. So the other two questions are, have you had contact in the last 2 weeks with others who have been unwell with respiratory symptoms or confirmed to have COVID-19? And then your third question is around that vulnerable patient. So is your patient or client at a higher risk of severe illness? So if there wasn't yes to any of those two, it is still good to protect them, and that would be to wear a surgical mask if you're up close, irrespective of the type of care. Now, there haven't been guidelines that I'm aware of yet from your government around whether you still should be doing this for vulnerable patients, so I'm just going to continue to talk as if this was level 2. So the reason we look at the vulnerable patient is that it adds a level of protection for that very low risk that you may be asymptomatic and be able to transmit that. It's a very low risk, but it just means that you're giving them that extra protection, a little bit like being in protective isolation if you're in a hospital. And of course, as well as that mask, if you're doing some other procedure that you may want to wear a gown and gloves, well, that would be your additional PPE for that. So the first part of this presentation was about going in to do the home visit. So you've done that assessment. So if it was someone who was a probable or confirmed COVID-19 or a contact for COVID-19, you do need to take precautions. So before you go in the home, make sure that you've got all your stuff ready. So have your PPE ready, have your cleaning wipes, waste disposal bags, and a thermometer if you're going to do some temperature screening. Also have an emergency backup PPE kit, and that would also include, as well as a surgical mask, a P2 or N95 mask, and some eye protection, apron, gown and gloves. So that would be particularly important to have at the ready if you were back in the situation where there was high community in your area, or there was an outbreak situation. You should have that in case when you do your assessment, you feel that you need to use that. If you come to the house at level 2 while you're in the car, if you need to wear your PPE because the patient is confirmed or suspected, there is a few scenarios when you would put on your PPE. So the PPE you're looking at is that the personal protective equipment you use for contact and droplet precautions. So some people might put the mask and eyewear on before entering their house. Some people might put the mask on, everything on just at the doorway. Some people might put it on once they've gone into the house, maybe in the hallway when they're, and that should say more than a meter away. But remember, because of the 5 moments for hand hygiene, your gloves should not be put on until you're able to clean your hands before you have direct contact with your patient and client. So let your patient know that you've come. Just give them a ring if you can, speak to them from that distance, check that there's no new risks in the house. So for example, is there anyone else in the house that's developed symptoms? Make sure that there's no one else is in the room, including pets, and that they're still well enough for a home visit. And then just explain to them why you're going to be wearing certain PPE and what PPE you're going to be wearing. And remind them if they are positive or suspected that they also need to wear a surgical mask and that they need to clean their hands before we come in or you go in and actually start doing some cares. So some of the things just to go over activities while in the home related to COVID-19. So if you're somebody that goes in to do cleaning, for example, normal household products are fine in the patient's, in the client's home. You don't need to be taking in special disinfectant products. This is the client's home. You can use what they always use. But remember to just clean, focus on those frequently touched surfaces and make sure they're clean. Always do your cleaning in a logical manner where you got an S. This is one way, an S-shaped pattern from top to bottom. You always write from clean, sorry, wipe from clean to dirty. Disposable cloths are preferred, but otherwise make sure the cloths go in the washing machine at the end of the session. They should go through a proper wash in a washing machine. Otherwise, you should be using disposable cloths. And if you can clean more than, if you're cleaning and you can be situated or located more than 1 meter from your client, then you only need to wear your gloves and apron. However, if you have to get up close to the clients who are suspected or positive, you need to be wearing your mask as well. If you're cooking for a client, remember that COVID-19 is not transmitted by food. So there should be nothing special to do with cooking. As always, you should always have clean hands and always practice good respiratory etiquette. But your normal food safety preparation practices apply. So there's nothing special for cooking. Maybe you're somebody that has to do some laundry. So these are some specific things that we thought of for COVID-19. So one of the things is don't shake your dirty laundry before washing. That just minimizes dispersal of the virus into the air. And just wash as normal. So just the normal, you know, instructions for cleaning your laundry. Dirty laundry that's been in contact with another person can still be washed with their other items, other people's items. This is not norovirus. That virus is very easily killed through normal laundry procedures. You can still take your laundry to a public laundromat. Obviously, if something is heavily soiled with blood or body fluids, then, you know, it should be disposed of. You shouldn't try and do one of those sluice type pre-cleans with the owner's consent, or they can decide how they want to manage that piece of clothing or linen. Then this is still in the context of a suspected or positive patient. At the end of the visit, make sure that all the external surfaces of your kit are cleaned down with your wipes before putting back in your car. Perform your hand hygiene. Make sure your kit is restocked at some stage as required. Before you leave the house, remind the client to, you know, because they're positive or suspected, to regularly clean any equipment that they might have in the house. So for example, they may be on nighttime CPAP, any wheelchairs, walking frames, you know, blood glucometer machines, because these can easily become contaminated with the COVID-19. And also remind them about regularly performing hand hygiene, hand washing, or using an alcohol-based hand sanitizer product. Now, if you're going in to visit clients and neither them nor their household members have any symptoms or risk factors for COVID, there really is no change. You shouldn't be doing anything different. At level 2, we were still promoting a physical distancing, but it's using standard precautions. There shouldn't be any universal mask use. There shouldn't be anything different except they came under that risk assessment for a vulnerable person. And this is what it'll be like now, I would imagine, at level 1. However, if you're visiting a client and they have a household member who's in quarantine, so you could be visiting Mrs. Jones, but the son lives in the house and that person has been identified as being a contact or is someone who's in home quarantine. First of all, you know, consider postponing your visit. Or you can ask that household member who's quarantined to stay in another room for 30 minutes prior to visit. So not to just suddenly walk out of the room just before you come, but get them to go into another room. So get the son to go into another room and be there at least 30 minutes before you come. And you do need to check that that person is able to remain in a different room. There may be reasons that they can't do that. So there may be behavioral or cognitive issues. Maybe it's a partner who has got some sort of dementia. Maybe they choose not to comply. They want to be with the person that you are visiting at the time, or they need to be to help you. So it may not always be possible that another household member who's in quarantine can absent themselves from the room that you're going to be doing your work. So in this case, you would need to use your droplet and contact precautions before going into the home. Try to maintain that distance and try and distract that other person if there's cognitive issues by asking them to watch TV or listen to music, and also ask them to wear a surgical mask and perform hand hygiene. And if possible, you know, if it's still not working and you feel there's too great a risk, you can always leave and reschedule the appointment. So that hopefully that scenario is hopefully not going to happen too often now, but we never know. So these are just some tips if you did have that sort of scenario. So I'm just going to move on to the second part of my presentation, which is really about the elderly in rest homes and aged care facilities. And as we know, this has been an absolute disaster, this pandemic, for our poor elderly, more so in the rest of the world. And this is a graph on the left, which shows the mortality of the total cases associated with outbreaks in care homes. So in other words, Norway, 64% of their deaths were from care homes. Now we know Norway's total deaths have actually been quite good, but that's a very high percentage. Canada's high, Ireland, sadly, and I've got an Irish accent, has been very high. And I have a 91-year-old mother, but luckily she's at home, so she's not in a care home. And Spain is high, so they're all high. I mean, Singapore is low, Australia's quite low, but saying that, like New Zealand, a lot of our cases have actually been still from rest homes. Of course, we've had a couple of big outbreaks. And in the UK, I just pulled out a headline there because it has been particularly hard hit. You know, there's like thousands of care homes have been affected by COVID-19. So it is the weak point. So now that you're going into level 1, you're elderly in your care homes, it is still the weak point. Even when it's low prevalence, this is the area where you're going to get your outbreaks, almost certainly. In Hong Kong, they've had no outbreaks in aged care, but they've had no visitors allowed since the end of January. It's been highly draconian, and they've had staff wear surgical masks the whole time. Now, there are pros and cons of that, but it's just putting it out there. Korea is another good example. They've had very little, and in April, they tested thousands of residents. 10% of their rest homes were tested, and that's 6,544 residents were tested for COVID, and there were no cases, but again, they've made staff wear surgical masks the whole time. And then there's been another recent report, which has been an excellent description of an outbreak in a long-term care facility in King Country, Washington, the States, and they had a huge number of cases, and this is their graph. So they had nearly 180 cases, and this was because some of the reasons for this was healthcare worked across a number of different facilities, and this was a very large outbreak in a rest home in the States. And you can just see there, although it started with the first case on February the 27th, there was still a large number of residents on March the 10th because of that incubation period. And some of the problems here was there was it was not picked up early enough to implement procedures. So some of the ways you can prevent your outbreaks now is go back to business as usual, but really embed your infection prevention control. What has come out time and time again with the aged care facilities is that although they may have had PPE training and infection control training in there, it really wasn't robust enough. There wasn't enough of it done. You need to train with PPE and get people to practice putting it on and off safely. Get them to be familiar with what a mask looks like. You know, staff will still, if they're not used to it, they'll take that mask off out and they'll put it on the wrong way round. They'll remove it in an unsafe way. These are really, really important basic standard precaution stuff to reinforce with your staff. Make sure you've got your supplies, that your supplies meet standards, that they're not some flimsy paper mask scenario, that your gloves are decent gloves, etc. Have your outbreak plans in place. Have some sort of a template rostering system where you can divide your staff either into teams or into wings of a home, or some way that you can manage in an outbreak scenario that your staff are not mixing and matching, and therefore, you know, your whole staff have to go down. Look at that team scenario. Also predetermine where you might want to isolate your residents. Now, it is difficult in a scenario where your resident owns the room or they're paying for a certain room, but you do need to think about the wings of your hospital and how you might close off certain wings or certain buildings so that that's already predetermined. The other thing is, of course, your early recognition in the elderly, so that they can then be tested, and then you can then implement infection prevention control and education for everyone. So at times of community transmission, and maybe ongoing for a while into level 1, you want to be making sure that there is a clinical assessment every day of every resident. So not only are you looking for signs and symptoms of respiratory illness, but if your workers are not clinical workers, if they're people that are not trained to do clinical assessments, there are things questions they can answer every day and record. So is the resident different? Like, are they not themselves? So your long-term workers will know how a resident is. They will know if they're off, if they're just not themselves, as it were. Are they needing more help with tasks? Are they sleeping more? Are they getting very upset, angry, or are they wanting to stay in their rooms? These are some of the ways that elderly can manifest illness without necessarily showing signs and symptoms of respiratory disease. So it's a good little questions for your non-healthcare carers to be asking. Now, if you want to look at, if you're in the long-term care or aged residential care business, this is a very recent article which describes a lot of the symptoms and a lot of the ways that elderly people manifest COVID-19. And it is a free, as you can see, a free access, but it's a very good description of how the elderly have shown their signs and symptoms during this pandemic period. So if you do get an outbreak, try and identify it as early as possible. Implement your infection prevention control measures early on. Make sure that respiratory people are tested, notify the authorities, notify and get help on board if you haven't got enough expert infection prevention control advice. Early on, restrict movement activity, monitor it. When it's over, declare it over it, and review your things. So those are some bullet points of what to do and manage an outbreak. Now, if we look at the New Zealand outbreaks, this was the latest graph that I found about 6 days ago on the ministerial site, and these are clusters under investigation, and I've just highlighted there, you know, despite New Zealand doing really well, you still have had a number of aged residential care facility outbreaks, and you know, a lot of cases, and it's the same over here. And we have had a couple of high profile care home outbreaks, and I'm going to pull on some of the learnings from my colleagues to share with you from those. So some of them, these have come from my colleague Cathy Dempsey, who manages infection prevention control at state level, New South Wales, and she's been involved in 2 large care home outbreaks in Sydney and outer Sydney. And so some of these tips have come from her. So she said, you know, so things are, make sure that there is an outbreak management team within hours of a positive case. Don't wait for the next day. It is an emergency. You need to set up that outbreak. As soon as you know someone, or a strong suspicion someone's positive, get your outbreak management team on board. But also identify, where is the outbreak? So is it the whole complex? Are we talking about one wing and one building? You need to make that very clear. You need to not just be including everything at that stage if you don't need to include everything. And what everyone has learned from all these outbreaks is that it is useful to test all residents and staff as contacts, because they may have asymptomatic carriage. And another little thing is, you know, not have the whole place as an inverted commas dirty or contaminated area. Allow there to be clean spaces for staff to go where no PPE is allowed. So designate and, you know, make it very clear with markings or whatever that staff can go and have their lunch, and there should be no PPE in there. They're not allowed in without cleaning their hands, etc. But these are almost like safe places for staff, because if there is an outbreak in a residential care home, it is really hard on the mental health of staff dealing with that. And the anxiety for them catching COVID is huge. And you need to look after the mental health of your staff as much as you do if you're elderly or your residents, clients. So try and find somewhere clean that's totally away from the PPE areas. There's also a lot of tips out there on how to manage your wandering patients or wandering residents, those who you can't lock in the room, so to speak, or keep contained. And some of those things include, you know, maybe you have to have a carer assigned to, inverted commas, follow that client, you know, follow that patient. Maybe you can contain them to a certain 2 rooms so they can wander, as it were, but they're not coming in contact with anyone else. Or the person following has to sort of use cleaner on touch surfaces. You still have to realize that these people are still going to be a risk. So with the 2 outbreaks here, there were 2 different trajectories. The one place that did better than the other was that they very early on got in the experts in IPC. And I know from experience that many of our rest homes have an RN who has a designated role for a couple of hours a week doing infection prevention control. You need to get more help than that. And the earlier the expert comes in, the better it can be managed. You need to do lots of training with lots of practice with your carers. A lot of these people will never have anything more on than gloves or maybe an apron. And it would be unusual that many of them would even be wearing a mask. And make sure that your PPE is familiar. One of the rest homes, the owners threw everything in there. So when the IPC expert walked in, they found staff wearing hats, wearing booties, wearing all sorts of unfamiliar PPE. And as we all know, that brings added risk of self-contamination when taking it off. And it really wasn't necessary. You need to monitor the PPE and the cleaning practices and hand hygiene practices every shift, every day. There does need to be someone on who is pretty well watching what's happening and really being strict about talking to staff and reminding them of the right thing to do. Remember, your staff may not have English always as their first language, so their main language. You know, signage needs to be visual, needs to be icons, not reams of words that someone may not take the time to read. And also you want to prevent those, you know, you need to have written procedures so that people are not giving instructions to the next person that comes on the shift and it gets watered down or it gets changed. And we know that happens all the time. But you also, the communication is so important to families and residents. A lot of the stuff out there, the negative communication stuff has been the families haven't been kept up to date with what's happening. Because they're locked down, they're not being allowed to visit, etc. You must listen to staff concern. We all know that COVID-19 has got a heightened concern for staff. And while some of us in the profession realize that a lot of that concern is not based on evidence, we can't disregard it. We have to listen, we have to try and provide evidence as to why they are safe. But on the other hand, don't give in to sort of unreasonable demands which sends the wrong message. So if staff are saying, I'm not going in there unless I have got a coverall to wear, for example, you can't just go with what everything a staff member wants in terms of PPE, for example, because it does send the wrong message and you're saying to others, well, it's not safe if I don't wear the full PPE. Another tip is use magic tape on the floor. We all know that bugs can't jump over the red line, but it is actually very visual and it can help to remind staff not to walk over that tape if they've got their PPE on, for example. So a little thing about visiting, again, this is probably out of date now, but the visiting was always and still is a huge bone of contention because the elderly suffer so much with social isolation. But the visitor, this is all from the Ministry of Health New Zealand, and what it's saying is that it's really down to the healthcare facility, down to that actual facility or organisation to decide who and how long and what type of visiting can work. But Visitors, unlike normally, they would be required to use hand hygiene, physical distance and PPE. In Australia, pretty well no one could visit, but as you can see in that photo, there was some cases where you could have drive-by visiting. People were stood at a distance outside windows, outside fences to see their loved ones. And now in level 2 external contractors were able to go back in to start, fixing those leaky pipes, etc. So that's all I was going to just touch on. As I said at the start, I wasn't going to give you a blow-by-blow account of how to manage an outbreak in a residential care facility. There are lots of guidelines out there, but I just wanted to give you some tips or some information that we picked up from the outbreaks that have occurred over here. So the final little section is, there's been a lot of talk and quite a few studies now come out with the extended use, particularly in other countries. The wearing of PPE for long periods of time has resulted in staff getting injuries, but there are a number of hazards associated with the use of personal protective equipment. So there are biological hazards, so that is the risk from contaminated PPE. There are your ergonomic sort of hazards and injuries, that's movements and performing tasks are affected. There are human factor hazards, and then there are the physical hazards associated. So I'm just going to touch briefly on some of these. These are sorts of things that could be useful at any time. So your biological hazards, remember that PPE is at the very bottom of your controls for managing, say, a blood-body fluid exposure. Using PPE is that very bottom of that triangle of controls. So it is the least effective. And while it is there to protect you from body fluids and pathogens, it in itself gets exposed to those, and so therefore you will have contaminated PPE on yourself, and so that then becomes a hazard in itself. So that is a biological hazard. Your mask is a biological hazard, your gown is a biological hazard. Although it's protecting you, it's a hazard in itself. So you should always remove it promptly and always the correct way. So there's a lot of talk about and a lot of evidence to show that taking off PPE incorrectly is very easy to contaminate yourself, right down to the basics of removing an apron or a gown, gloves, and especially masks. So all of those pieces of equipment, there are safe ways to take them off. I wouldn't get too hung up about, there are a number of different ways of removing, a couple of main ways of removing gown and gloves. For example, you can remove gloves first, then your gown. If you choose to remove gown and gloves together, that's also a safe way. The key message is you clean your hands off, clean your hands after you take gloves off. So it doesn't matter whether you move it separately. Every time your gloves come off, you clean your hands. But both those ways are safe, and both those ways have been endorsed by the CDC and the WHO. I'm not going to go into all the safe ways of removing PPE. I did that in my last presentation. The other thing about any sort of pandemic is that you do need to look at were there any significant breaches. So when you use a higher level of PPE that's more complex, you often have a trained observer or a buddy or an assistant. And if you've got another healthcare worker also in the room, they may notice that you've contaminated yourself via incorrect use of PPE, either during use or when you're taking it off. And that may be significant enough that you would then become a suspected case. So you could flip your mask up into your face inadvertently, for example, and you'd been in the room of a positive COVID patient. That would be enough to then, you'd be on quarantine and you'd be investigated as a suspected case. The ergonomic hazards are more about how clumsy it is using PPE and doing your task, and how that impacts on how you do it. So it's harder and it takes longer, and the more the more people in the room who are using that PPE makes it harder because you're trying to avoid each other, and it just makes life harder. As we know, gloves can reduce your manual dexterity. It makes fine movements more difficult. when you're wearing goggles or face shield, they can fog up. It can impair your vision for sure, and that means you could have an increase in risk of slips and trips, etc. And your gowns can impair movement. So sometimes people find it harder turning patients if they're wearing a gown, therefore it could lead to more back injuries, or they might catch on objects. We know, for example, with the paramedics and their ambulance staff, we've had cases of gowns and aprons blowing up into their face, you know, not very practical. So, you know, there are all sorts of ergonomic hazards associated with our various PPE. Human factors is if you're wearing PPE, you do need to allow additional time for and frequency of breaks, fluids, toilets, etc. You definitely, it increases the fatigue because you can't necessarily sit down as often. If you're wearing a lot of PPE, it does add a certain amount of weight. And the fact that you are concentrating more, maybe because your vision's not good, maybe you're having to talk louder because someone can't make out what you're saying, that increases tiredness, and therefore you may need more breaks than normal. Now, the final thing that I want to look at about hazards to do with PPE are the physical hazards. So the main physical hazard associated with PPE are skin injuries. Now, many of you will have seen a lot of the pictures that have gone out there, some of the sort of blogs to do with nursing especially, and these are usually caused by when we've had staff having to wear PPE for long periods of time. Now this has happened not just, these pictures are from the UK, but this does happen also in Australia, and I'm sure it's happened in New Zealand in some of our healthcare facilities. So the skin injuries we get are reddened skin, sores, chafing, bruising, and in some instances are skin tears. And they're related to they're related to the device, the pressures of device, and also moisture associated skin injuries. And we have had input from wound specialist nursing staff and wound specialists into how we might be able to manage or prevent some of these. So they are caused by a buildup of pressure if it's a mask and moisture behind the mask. So those pictures, for example, are both pressure and moisture related injuries. But it's not just the tight fitting hard shell P2 type mask. Any surgical or P2 mask, N95 mask, can be responsible for skin damage at the various pressure points. Also the goggles can also cause pressure damage. The masks particularly cause damage across the top and across the bridge of the nose. The visors can leave marks on the forehead, and the masks also around here if they're tight fitting. The loops on masks have definitely caused problems at the back, behind the ears, and the goggles damage under the skin. So there are a few things we can try and do to prevent this. I mean, obviously the most obvious is to try and not have to wear the PPE. Now, overseas, this is with the shortage of PPE, this has been really problematic, and staff, to keep themselves safe, have had no choice but to wear PPE for 4 hours, mask for 4 hours or more, which is a hugely long time. If you talk to the wound specialists, they say really you should only wear them in the maximum 2-hour stretches, and this is to give the skin a chance to recover and dry in between use. It appears that masks with ties cause less rubbing, but then they aren't as handy to put on, and they're not necessarily as easy to find. If you have a poor fitting mask, that can cause rubbing, because if you're constantly going to adjust your mask, then you're adjusting it and you're touching your face. So if it doesn't fit properly, it's a potential obviously to cause irritation. So always make sure that you take time to make sure that your mask is fitted as well as you can get it to fit. And if it is a P2 mask, make sure you do your fit check. Don't over tighten it if you don't need to over tighten it. Some people are using skin protection dressings, and some of these names are not necessarily available in New Zealand. I thought they were, but you may not recognize them. So you've got self-adhesive tape. So these are the sorts of tape that are used on skin in the medical field, and there's a couple of trade names there, and the sort of thing that go on the stoma bags, that sort of thing. Other people have been using really, really thin, those little wound dressings like Mipilex, very, very thin ones of those. Other places are applying skin protectants and skin sealants, such as Cavalon, and they go on before the PPE. Now, you have to let that dry, obviously, before you put it on, and you should always check your seal if using a PT mask. So this has been the big thing. Does it interfere with the airborne properties or the airborne properties of your P2 mask if you're wearing it with that type of mask? So they have been used successfully with those types of masks, and sometimes we're using these masks really when we don't need to. We're using them more as a tighter surgical mask, in which case it's not that crucial. So just think about that. And it's always the thing that comes off last. So don't try and remove your dressing before you take off any other sort of PPE. This is a very a neat little poster that I found from, I don't know if it was Canada or the States, and it was a pressure injury advisory panel, and it was just about how to look after your skin for this extended use of these N95 face masks. And remember, in these countries, they really, really were wearing them for hours at a time. Just showing the time. And as I said before, there have been a number of pieces of research come out in the last month about this, and mostly through authored by wound specialists. So this study was a very big study in China and across a lot of different places, and they looked at doctors only, and they found that nearly 43% of doctors had experienced some serious skin injury with PPE, and that included the whole gamut of PPE. And the factors that the aggregating factors that were significant were that they were sweating a lot in their PPE, the long times they were having to wear them during the day. If they were male, they were more at higher risk, and the higher level of PPE, higher level. So if they were wearing coveralls, if they were having to wear a face shield as well as a mask, for example, that was an aggravating factor. So that was all that I was going to talk to you today. I hope that you find some of that useful.
I thought I'd just remind people, you mentioned your previous presentation. Some people might not have seen that.
Yeah.
All you have to do is Google mobile health and webinars, and you'll see all the presentations that we have done via webinar, and Ruth's previous presentation is there. So obviously you had some really detailed information in there, Ruth?
Yes, yeah, I particularly focused on personal protective equipment in that presentation because, I've forgotten now. Ben Harris had done a more overview of the epidemiology and the status of COVID previously the week before. Right. So I did a focus on personal protective equipment in that presentation, yeah.